Hello. So my disclosures. So before I did this presentation, I had a short exchange with John to ask him what we mean when we say biomarker. Yeah, so I see various definitions. Some only talk about lab tests as biomarkers. Yeah, others include imaging biomarkers. So I decided to put as a first slide this definition from the FDA, yeah, which I find very useful and simple. Yeah, so they define a biomarker as a defined measurable characteristic, and it can be basically every measurement value that indicates a disease or the absence of the disease. Yeah, so for example, body temperature is a biomarker. It's something that you can measure. It's something that indicates with a certain accuracy presence or absence of disease. And this then includes, of course, also all imaging radiology findings as well as lab tests or other tests. Yeah, so I will speak about biomarkers in this broader sense, not only lab tests. So this is a reminder that we already have an excellent biomarker when it comes to lung cancer screening. Yeah, I think one of the biggest insights in the overall research was that the decisive biomarker is growth. Yeah, so growth, David taught me, is a clear basic feature of cancer, yeah, and something that doesn't grow is very unlikely cancer, and something that grows is very likely cancer. And I think this is something that brought lung cancer screening enormously forward, yeah, to have this notion of we assess growth as a biomarker and not necessarily size, yeah. So this already works very well, yeah. So this is a chart from a publication of Jeffrey Young from MGH. Yeah, he listed all the studies on the rate of benign resections. Yeah, we just got one added line from Maurizio Infante. Yeah, and also I think if I got the small print right, you set a new record with 2.1% benign resections. Yeah, so congratulations to Italy. and we see that over time, this rate of benign resection significantly improved. In the very first studies, NLST Nelson, it was relatively high. Then with improved guideline, with more experience, it became lower. We see that Europe is a bit better than the US. Yeah, so an interesting observation, which is now confirmed by Maurizio's numbers, yeah, and the new screening programs are on an excellent range. Yeah, so also we have an excellent sensitivity. We have almost no overdiagnosis. We saw it in the first day from Rowena. So lung cancer screening with low-dose CT finds almost all cancers, and it finds the right cancers. So it simply works very well. Yeah, this sets the bar pretty high for anything we want to add. Yeah, if you jump 2 meters, it's probably easier to break the record than if you jump 8.90 meters, then it may hold 20 years. Yeah, so this is always something we have to consider. Another topic for new biomarkers in lung cancer screening is always where to add them in the workflow. Yeah, so here I pinned down a bit how lung cancer detection and screening program works. Yeah, it's very simple. You recruit patients or participants, you do a CT scan. If the result is inconclusive, you do a follow-up scan, you assess growth, you do a biopsy, and then you do definitive treatment, surgery, SBRT, and ablation. And you can put tests in every of these steps. Yeah, I added some examples. Yeah, we have the multi-cancer detection tests, which claim to be better recruiting patients or covering populations. We have things like Sybil that from the first CT scan predicts the risk and may help to avoid further CT scans. We have things that improve CT accuracy, or improve malignancy classification, differentiation of malign or benign disease, and therefore save us from follow-up scans. We have molecular biopsy that in an identified growing lesion may avoid the real biopsy and allow directly jumping to definitive treatment. All this have not been really become standard of care, yeah, because they all have certain shortcomings. Yeah, you all saw the recent results on multi-cancer detection tests. It's still limited. Something that is has probably less awareness is if we would do screening with a multi-cancer detection test. That would be a completely new screening program. Yeah, so we would need to go to USPSTF, to all the policy makers, discuss this all from scratch. This would be a very time-consuming and very long effort. So it's much easier to put any biomarkers behind the CT, because then it stays CT screening, which we have, and just add something. Yeah, and then we have the other restrictions. Yeah, I had the discussions with David on speed of growth versus likelihood of cancer. Yeah, can we really skip CT scans and have longer intervals if Sybil tells us a low risk? We have the accuracy tools that would need a really high PPV or NPV to jump directly to a decision. Yeah, which I currently don't see. And in the liquid biopsy space, the tools often have challenges in very small nodules. Yeah, so you still need a conventional biopsy. So these are a bit the limitations. And always, if you think about a new biomarker, tell me where it fits in the workflow and what it adds. Yeah. So then I come to the main topic. Yeah, the biomarker for other diseases. Now we talked about adding biomarkers to lung cancer screening, where I said already working well, high hurdles to add something. Now to the other diseases. Yeah, this is a study from Korea that shows incidence and hazard ratio. I already showed it for various incidental findings. And you see there are the leading three: coronary artery calcifications, emphysema, a bit more rare, but with a higher hazard ratio, the interstitial lung abnormalities, and then the rather rare but severe incidental findings. Yeah, so then we can have a look at the biomarkers, and this is also only very short, and also my personal view. Yeah, I see a lot of people who have spent much more time with this. So for cardiac diseases, we discussed a lot coronary artery calcifications. Yeah, I think we learned from the survey, most people reported either qualitatively or quantitatively. If you ask me about what is needed, yeah, I think it's needed to have more clear recommendations on actions, yeah, and also an integration with clinical scores like Framingham, cholesterol, and so on. COPD, emphysema seems to be a bit more challenging. It's sometimes reported. It's largely qualitative. I think their recommendations on actions, and especially on actions that a primary care physician can carry out, would be very important. Yeah, if we, for example, look at Germany, the eligible population for lung cancer screening is 3 million people. Roughly 1/3, 1 million, will have some sort of emphysema or COPD. We saw the numbers. Yeah. In Germany, we have around 600 pulmonologists doing outpatient work. Yeah, so if you write in a guideline, consult pulmonology, you have to consider that this could mean that 1 million people identified in screening with COPD want to see 600 pulmonologists, which is an obvious challenge. Yeah, so I think we always have to see that the report from the screening largely goes back to primary care, so it should contain recommendations that primary care can follow. Yeah, and I think this is well done for prescribe a statin. Yeah, the patient has high calcium, cardiac risk, please prescribe a statin. This is something that primary care can do. In COPD, I think it's much more challenging. And a bit even more challenging is the whole topic of interstitial lung abnormalities, interstitial lung diseases. Yeah, there is now the new ATS guideline that recommends reporting on this in lung cancer screening scans. On the other side, we have still a significant inter-radiologist disagreement and difficulties to quantify, measure this disease. I think this is really something where we will need more automation and AI and also further studies to work on this. So this is already my summary. Yeah? So regarding biomarkers, we have a really excellent biomarker in lung cancer screening for lung cancer. This is lesion growth, yeah? So change in volume over time. We have the potential to improve lung cancer screening by adding lab biomarkers, radiomics data. We have not seen a breakthrough yet. And as I said, the hurdles are pretty high because we want to improve something that already works very well. Always the question for me is, at which step of the workflow or pathway can you add value? Where do you place your marker, whatever it is? And then for other diseases, we have biomarkers, yeah, but I always ask the question, are they actionable? And the other question is always, is qualitative assessment good enough, or do we need quantification? We also had it in the survey. Some people say qualitative is okay, others want quantification, but the key is always actionability. Yeah, so what to do, and preferably in primary care. That's all from my side. Thank you very much.